Hello, Assalamualaikum and good morning to all. My name is Dr. Yang Rafida Hassad. Can call me Dr. Yang. I'm a visiting lecturer in Orthodontics. Today will be my very first lecture in Ortho, which is Orthopedic Appliances. If you have any question regarding this topic, you all can email me at this email, rafida@pidc.edu.my. These are the three main orthopedic appliances that I will be covering in my lecture. The first one is headgear, the second one is reverse pull headgear and also known as face mask, and the third one is chin cup. By the end of this lecture, you should be able to outline the indication, contraindication, and the uses of headgear, reverse pull headgear and chin cup. So this lecture is divided into two parts. The first part is headgear and the second part will cover the reverse pull headgear and chin cup. So now let us focus on the part 1, which is headgear. In orthodontic practice, there are two types of forces. The first one is orthodontic forces and the second one is orthopedic forces. So what does orthodontic force do? It moves the teeth. So how does it move the teeth? By means of wires and other active appliances. So forces from this orthodontic force are very light and range from 10 to 120 grams. Whereas for orthopedic forces, it affects the deeper craniofacial structures, and these are heavy forces over 400 grams that can bring about a change in skeletal tissue. So, what is the basis for orthopedic appliances? So, orthopedic appliances will use heavy forces, and these heavy forces applied to teeth have the potential to radiate upwards and affect the nearby skeletal structures. For such skeletal changes to occur, forces employed should be over 400 grams. Thus, orthopedic appliances uses teeth as handles to transmit the forces to the adjacent skeletal structures. Nowadays, they have mini plates and mini screws that have similar effect of the orthopedic appliances. However, I will not explain this because this topic is beyond the scope of this lecture. Now let us focus on the factors affecting orthopedic appliances treatment. There are 4 factors that affect the orthopedic appliances. The first one is the amount of forces. The second one is the duration of forces. The third one is the direction of forces. And the last one, the fourth one, is the age of the patient. So now let's focus on the amount of forces. The force magnitude should be high, at least 400 to 600 grams per side, to make sure that only skeletal and no dental movement takes place. Such high forces produce hyalinization, which prevents or slows down tooth movement, and thus only an orthopedic movement is seen. Second factor is the duration of forces. Extraoral appliances should be worn about 12 to 14 hours per day so that we can have the desired effect. Increasing the duration beyond the optimal range increases the dental effect. An intermittent heavy force is less harmful to the teeth and periodontium than a continuous heavy force. This is also influenced by the fact that 12 to 14 hours usage helps achieve better compliance from the patient while achieving the desired skeletal changes. There is evidence that there is an increase in the release of growth hormone more during the evening and night, and it is associated with the sleep onset. Hence, nighttime wear is recommended. Direction of force. The direction of force application should be such as to maximize the skeletal effect. If no rotation of the maxilla is desired, then force is directed posteriorly and superiorly through the center of resistance of the maxilla. But the direction can be altered above or below the crest if rotation of the maxilla is also desired. Age of the patient depends on the malocclusion. For example, correction of the retrognatic maxilla using a class 3 malocclusion has to be corrected as early as possible, whereas correction of class 2 due to prognatic maxilla can be done as late as around puberty, unless there is indication that the child is experiencing psychological trauma or is at increased risk of dental trauma to the anterior teeth. Some appliances like the chin cup used to redirect growth of the mandible have to be used till the patient reaches adult level of growth. This is because mandibular prognatism can relapse, especially if there is a strong genetic component to it. So what is headgear? Headgear is a device by which extraoral force is almost always applied to maxillary dentition via a face bow and a strap on the head or neck for anchorage. Now let me introduce to you the components of headgear. So the first one is anchor unit, which is a strap covering the back of the head. And then the blue colored one is the force generating unit that connect the anchor unit to the face bow. Face bow is a metal that connect the outer bow and inner bow to the teeth. This is the intraoral view of the face bow that connect to the teeth. So what happened is intraorally there is an appliance that have a components which connect the face bow to the appliances. So you can see at the bottom picture is something that looks like Adam's clouds, and at the bridge there is something connected, and this is what we call a tubing. This tubing will connect to the face bow and to the headgear. So basically we have three main components of headgear. The first one is the face bow, which is the force delivering unit. The second one is the anchor unit, which is the head cap or the neck strap. And the third one is force generating unit, which is the springs and elastic that will connect between anchor unit and the face bow. So face bow is one of the most important components which help in delivering extraoral force to the posterior teeth. The face bow consists of the following. Outer bow or whisker bow. It is made up of round stainless steel wire in size of 1.2 to 1.5 mm in dimension and is contoured around the face. The outer bow may be shorter. Outer bow is shorter than inner bow. Medium outer bow is the same length as the inner bow. Long outer bow is longer than inner bow. Inner bow is made out of 1 mm round stainless steel wire and inserts into the round buccal tube on the maxillary first molar. The inner bow is adapted according to the shape of the arch. Stops in the form of U-loops are placed in the bow mesial to the buccal tubes to prevent it from sliding too far distally through the tubes. Junction is the point of attachment of the inner and outer bow, which may be soldered or welded. It is usually positioned at the middle of the two bows, and it may be shifted to one side in case of asymmetric face bow. So this picture shows the stop that will prevent the face bow from protruding inside the tube, and also the junction. Force generating unit. This connects the face bow to the anchor unit and delivers the force to the teeth and the underlying skeletal structure. Depending on the extent to which the force generating unit is pulled forward, the amount of force exerted varies. The force element may be springs or elastic. Anchor unit. This is the form of head cap or a neck strap which makes use of anchorage from the skull or back of the neck respectively. A combination of two may also be used. This picture shows the plastic strap, outer bow or face bow, and the safety release. And also it shows the wire tube, middle or upper tube, the outer bow, arch wire, headgear tube, and inner bow. Principle of force application in headgear therapy. So now I will be explain one by one about center of resistance, the force, the point of origin of force, and point of attachment of force. Center of resistance is the point through which the resultant of the forces acting upon a body will produce a translatory movement. A force passing through the center of resistance of tooth will cause to translate or moving. So once we have a force passing through the center of the resistance, the tooth will move. If the force is directly at the center of resistance, we will have bodily movement, which is the whole of the tooth will move to the side. If we have a force which is from upward to below, it will cause the tooth to move downward and laterally. If we have the force passing through the center of resistance from downward to upward, the teeth will slightly intruded and move laterally. Alternatively, tipping will result once we have the forces above or below the center of resistance. If we have forces below the center of resistance, we will create a mesial root tipping. However, if we have forces above the center of resistance, the root will tip distally. The center of resistance of maxillary dentition is usually located between the roots of the two premolars, and the center of resistance of the maxillary bone is present at the posterosuperior aspect of the zygomatico-maxillary suture. Therefore, to bring about translation line of action of force, then the force should pass through its center of resistance. A force vector will have to pass through the center of resistance of the dentition and through the center of resistance of the maxillary bone if no rotational effect are to be induced. If the force is below the center of resistance, we will create a clockwise rotation of the maxilla. However, if the force are above the center of resistance, we will create anti-clockwise rotation of the maxilla. Headgears can be divided as follows according to location of anchor unit. So it can be called cervical pull headgear, occipital pull headgear, high pull headgear, or combination pull headgear. Cervical headgear. The anchor unit in this headgear is the nape of the neck. These headgears are generally indicated in low mandibular angle case. It causes extrusion and distalization of the molars along with distal movement of the maxilla. When line of force passes below the center of resistance in both maxilla and dentition, it produces clockwise rotation of both maxilla and dentition. When line of force passes below the center of resistance of maxilla and above that of the dentition, this produces clockwise rotation of maxilla and anti-clockwise rotation of the dentition. For cervical pull headgear, if the line of force, which is shown by the red arrow, if the line of force passing to the center of resistance. The center of resistance is the green dot. So on the first photo above, we can see that the line of force passing through the center of resistance, it will cause the molar to translate. Okay. On the middle picture, when the line of force passing through below the center of resistance, it will cause the molar to have clockwise rotation. So for the bottom picture, when the line of force is above the center of resistance, it will cause anti-clockwise rotation of the molar. Occipital headgear or occipital pull headgear. These headgears derive anchorage from the back of the head. This type of headgear produces distal and superiorly directed force on the maxillary teeth and maxilla. When the line of force passes below the center of resistance of both the maxilla and dentition, this produces clockwise rotation of both maxilla and dentition. When the line of force passes below the center of resistance of maxilla and above that of the dentition, it produces clockwise rotation of maxilla and anti-clockwise rotation of dentition. This picture shows the occipital pull headgear. So above the top pictures shows that the line of force is through the center of resistance. So remember, the center of resistance is the green dot and the line of force is the red arrow. So above photo, the top photo shows that the line of force is passing through the center of resistance. It causes translation of the molar. So at the middle photo, it shows that the line of force is below the center of resistance of molar. So it will cause clockwise rotation of the molar. And then the bottom photo shows that the line of force is above the center of resistance of molar, and it will cause anti-clockwise rotation of the molar. Combination headgear, meaning that the anchorage is both occipital and cervical. Both are combined in one headgear. So when the force are equal, a distant and slight upward force is exerted on the maxillary dentition and maxilla. By varying the proportion of the total force derived from the head, cap, and neck strap, sorry for the typing mistake, the resultant force direction can be altered. Now the treatment effect. The treatment effect can be skeletal effect or dental effect. So for the skeletal effect, the maxillary sutures, namely the frontomaxillary, zygomatico-temporal, zygomatico-maxillary, and pterygopalatine sutures are the most important growth site for development of maxilla. Therefore, to alter the maxillary growth, the headgears act by compressing the sutures, thus restricting the normal downward and forward growth of the maxilla, while at the same time the mandible is allowed to grow normally. Whereas for the dental effect, headgear being a tooth-borne appliance produces certain dental effect along with a skeletal changes. Headgears usually cause distalization on the maxillary molar. Along with this, extrusion or intrusion of the molar may also be seen if the extraoral attachment is cervical or occipital respectively. The uses of headgear. First is for orthopedic effect, to restrain the forward and downward growth of maxilla and redirecting maxillary growth. The distal force in such case should be applied through the center of resistance of maxilla. 350 and 450 grams on each side for a minimum of 12 to 14 hours per day is required. You must remember this is important. Orthopedic effect from extraoral forces are best tapped in pre-adolescent years. Headgear may be used to distalize the maxillary molar to correct the class 2 molar relationship or to gain space for relief of crowding. Extraoral forces can effectively be used for this purpose when worn for a minimum of 14 hours per day. Anchorage augmentation. Headgears can be used to reinforce molar anchorage in high anchorage cases. The headgear should be worn for 10 hours per day and force volume should be around 300 grams per side. In maxilla, anchorage reinforcement is achieved by restricting the mesial movement of molar. Molar rotation. Correction is achieved by adjustment of the inner bow so that it produces a rotational force on the molar. As soon as the correction is achieved, the face bow should be readjusted to apply a direct distal force. Space maintenance. Most effective method of maintaining arch length is by using extraoral force. Mesial movement of molars is prevented and the face bow does not interfere with erupting teeth. Daily wear of 8 hours per day is required. Limitation of headgear therapy. Headgear cannot apply force directly to the maxillary sutures. The orthopedic force have to be applied through the dentition and therefore dental changes are inevitable seen along with skeletal effect. Patient compliance is mandatory for headgear therapy to be successful. If patient compliance is poor, then the headgear treatment is not success. An adequate amount of mandibular growth is required to catch up while maxilla is restrained. However, this may not always be seen clinically. Accidental injuries are a possibility. To minimize this, patient instruction should be given in full and safety mechanism in the headgear should be employed. Precautions. Hold the bow in the mouth while the traction force is engaged or disengaged. Very rarely, facial and eye injuries have occurred. If this happens, treat this as a medical emergency and visit your local medical hospital immediately. Immediately hold and restrain the bow if it becomes loose. Never remove the whole appliance in one piece. Disengage the force element first, then remove the face bow component. No vigorous activity when wearing the headgear. No football, no rugby. Okay. Never wear the headgear without the safety device being in place. Report any damage or breakage of the appliance as soon as possible. Stop wearing the headgear and contact the orthodontist if the bow comes out at night. Safety mechanism in headgears. Generally, headgear safety mechanism involve either the release mechanism or the safety bow. The release mechanism releases the neck or head strap from the face bow if excessive anterior force is applied, thereby preventing rebound injury to the patient. The safety inner bow is designed to prevent the face bow from accidentally disengaging from the buccal tube or to decrease the ability of the inner bow to cause injury. This picture shows the example of safety mechanism in headgear. The first one shows an elastic band attached to an additional hook on the inner bow and to the hook of the molar band. So when patient want to remove the face bow, the patient should remove the elastic first, then only remove the face bow. They should remove the headgear one by one. The second photo shows the locking face bow. When patient wants to insert the face bow, patient should lock the face bow inside the tube. And then if patient want to remove the face bow, the patient need to unlock the face bow first before removing the face bow. And then the third photo shows the safety relief force element. The way it functions is when there is a excessive force and then the safety relief will disengage from the face bow. Okay, this is the last slide for part 1 of orthopedic appliances lectures. So now we will move into part 2. So as a recap, so by the end of this lecture, can you able to outline the indication and contraindication and the uses of headgear, chin cup and reversible headgear? Okay. Alright, so these are my references. Basically, this lecture is based on Dr. Vivek Bajka PowerPoint slide, and I add a little bit of facts from two of my main references is Orthodontic at a Glance and Contemporary Orthodontics by William Profit. You can have a look on this book or by other recommended textbook. Okay, that's all for now. Thank you for your attention. If you have any doubts or questions regarding this topic, you can email me at rafidah@pidc.edu.my, or you can approach me every Friday. That's the time where I'll be available in PIDC. And I hope you enjoy this topic very much and have a nice day. Bye.